Yeah, so this year at ASCO, they updated a presentation that was given at last year's ESMO. So last year at ESMO, they focused on the outcomes of patients in the combination group versus active monitoring. And then this year at ASCO, they updated the results to show the outcomes in the durva monotherapy group. So really to put it all together, last year at ESMO, they showed that the combination of durva plus tremi led to a disease-free survival benefit compared to active monitoring alone. That disease-free survival was 81% versus 73% in those patients with a hazard ratio of 0.65. That was statistically significant across the two groups. But when they stratified that hazard ratio by intermediate versus high-risk disease, according to the criteria that I mentioned before, the Leibovitz criteria, pretty much all the benefit seemed to come from the patients in the high-risk group. Their hazard ratio was 0.52, and then the intermediate risk population had a non-significant hazard ratio of 1.19. So this year, they presented the durva data, and then looking at the entire cohort, it was 790 patients, so a little bit over 200 in each of the therapy groups and almost 350, 340, I think, in the active monitoring group. They saw that the 3-year DFS was 80% with combination, 78% with monotherapy with durva, 72% with active monitoring. And there was not a benefit in terms of disease-free survival with durvalumab monotherapy. The hazard ratio there was 0.74, but the confidence interval went from 0.5 to crossed 1, so not statistically significant in the group overall, but also not significant either in the high-risk population. So, the overall conclusion is that the combination of durva plus tremi does have a disease-free survival benefit that seems to be concentrated in those at a high risk of recurrence. But the monotherapy, surprising to, some because of, the data we have with pembrolizumab, but there was no benefit in that regard. Yeah, so I think that these data, in light of the existing data and approval of pembrolizumab based off KEYNOTE-564, deserves conversation. But personally, in my practice, I think it would be hard for me to say that durva plus tremi should replace pembrolizumab. The reason is, while there is benefit, right, that we can see statistically, specifically in that high-risk population, there's real toxicity and quality of life impact that patients have to consider. So if you're adding, checkpoint inhibitors and CTLA-4 targeted therapy, you're really intensifying that attack of the immune axis, right? So if you look at the data presented data between ESMO and this year at ASCO, you see that only 23% of patients actually completed their durvalumab as intended, and up to 40% of patients, it was 40% of patients had serious adverse events with the combination therapy, and these were all immune-related events, colitis, increase in LFTs, pancreatic enzymes. So I think it's going to be hard to justify, exposing patients to that greater toxicity when we know that single agent pembrolizumab improves DFS, but also OS. That being said, I like the Leibovitz risk criteria. I think it's easy for us to calculate in clinic. But again, just like in all of our other disease spaces, these clinical pathologic risk stratification systems are very coarse. And I think that there is room for better biomarkers to guide these therapies. And there was a lot of discussion at ASCO about, how ctDNA and other circulating biomarkers like KIM-1 can risk stratify these patients. We're seeing some utility of these biomarkers, but it's not, the actual utility and benefit is not yet quite as clear in kidney cancer.
adjuvant therapy in Merkel cell carcinoma, I think, remains sort of an individualized decision-making process, based upon the patient's stage, the pathologic features, their risk of recurrence, or their perceived risk of recurrence. So it really still remains an individualized decision, and we still don't really know in the whole adjuvant space and skin cancer in general, whether treating the patient now as sort of a preventative measure is better than treating the patient if or when they recur. And I think that's important. Regardless, these patients have to be followed closely, whether or not they're getting adjuvant therapy. And I think, as we study more, and again, this is a rare population too, so this was actually quite a large study for Merkel cell, but I think based on the information we have so far, in some patients, adjuvant immunotherapy may be appropriate for patients who have, very high risk Merkel cell. I think as time goes on and maybe we learn more about how to predict which patients are actually going to recur, through the use of ctDNA monitoring or, other molecular factors or prognostic and predictive markers that are hopefully discovered. I think that's sort of how we're going to be making some of those decisions. The greater benefit was kind of seen in the patients who had sequential treatment rather than combined treatment. And so it's really interesting. I don't think we fully understand, why that is or what was driving that difference. It would be interesting to dig more into those patients and to understand if there was a difference, in those patient populations. Was there something about the patients who got sequential versus the combined therapy that was different? Were the stages significantly different? Was there something about the patients who were getting the immunotherapy concurrent with radiation? Like, did the treating investigator feel that they just needed to get on immunotherapy right away, and maybe the biology of their Merkel cell was sort of worse? And did that impact these results? So I think understanding a little bit more about the characteristics of those specific patients in the two groups would be helpful. But it is something really to keep in mind. And again, they weren't, it was small groups of patients, but it certainly was sizable enough for Merkel cell to kind of see that signal. So I do think it is something that we have to keep in mind, but also to try to understand like what the reason is for that.
It's a study that investigated Asciminib, a novel tyrosine kinase inhibitor, as initial therapy for patients with chronic phase chronic myeloid leukemia, compared to any of the available tyrosine kinase inhibitors approved for frontline therapy. The primary endpoint was major molecular response at 48 weeks, and the study met the primary endpoint. But we realized that although that's an important hallmark, since patients really stay on therapy for a long time and they continue probably experiencing resistance sometimes, adverse events, etc., the long-term follow-up becomes very important. So this is the first look at the 3-year follow-up of this study, or 144 weeks. So the important thing about showing these data is to show how the efficacy continues evolving, the difference between Asciminib and the other drugs, as well as the tolerability, to make sure that it remains well tolerated. Well, what it shows is that for one, we really haven't reached a plateau, a maximum of response rate with Asciminib. It would be expected that it'll take some time before we reach that. So, but it is also very important to remind us that although we are always aiming for the deepest responses, we get there eventually. So maintaining patients on therapy, especially if they're tolerating the treatment well, is very important. as we get to those deep responses. They're not going to happen in the first year. They may happen in a few patients. Sometimes they do. But the important thing is the perseverance, continue on therapy, and maintain the patients. We don't know how far these responses are going to go. We are close to 80% now with the MMR, and we are actually about 50% in the MR4, which is the deep molecular response. So very encouraging, but it is still going up. So we'll see how far they can go. That's been a very good asset of Asciminib, the fact that it has a very good safety profile. It's well tolerated. Most patients can continue on therapy and experience very little or no side effects. The treatment discontinuation due to adverse events is half as frequent or even less than with the other TKIs. So we are trying to get as many patients off therapy by improving their response, but realistically, many patients will remain on treatment for a long time. So these better tolerability becomes very valuable. And we've had some complementary data to these showing quality of life, patient-reported outcomes, and other elements, the percentage of days that the patient stays without adverse events and so on. And all of this show that they are better tolerated. So that's good news for the patients who are going to be taking the drug for a long time.